Hello again. I'm Richard Knight, President of the American Association of Kidney Patients. Thank you for joining us for the 47th Annual National Patient Meeting. As part of the AAKP initiated Decade of the Kidney, AAKP has purposefully targeted kidney research as a strategic priority for involvement and impact. Our national and global patient advocates and affiliates have been actively reaching out to all involved in the kidney science and research enterprise to offer their expertise and insights. At AAKP, we know that medical innovation and public policy are shaped by research, and without patients as active partners, future innovations in kidney disease and kidney disease care would not reflect our practical insights and lived experiences. Further, since research impacts public policy, including regulatory decisions and issues related to what new drugs and devices are paid for by government and private insurance, it is critical that patients work alongside research experts. Again, this is why you see so many messages from AAKP about opportunities to join a research project at a university through the federal government or PCORI. Our goal is to populate and impact every single kidney research project underway in the United States and across the globe. And as you will hear, we have been helped by research professionals in academia and government who want to work with you and AAKP. For today's session, Patient Consumers, Elevating and Including the Diverse Voices of Patients, I'm pleased to welcome several presenters whose work and personal commitment are for greater care choice and ending desperate health outcomes among communities who suffer the most from kidney disease. Our final two panelists will be presenting jointly. Dr. Keith Norris, a member of AAKP's Medical Advisory Board and professor of medicine at UCLA Division of General, Internal Medicine, and Health Services Research, and Dr. Katina Lang-Lindsey, assistant professor at Alabama Agriculture and Medical University, an AAKP ambassador, and a kidney transplant patient. Doctors Lindsey and Norris, I turn it over to you both.
Hi, I want to say thank you, Richard, and thank you, AAKP, for having us here today. I am Katina Lang-Lindsey, and this is a great honor to be here to present about structural racism. So today, what I would love to talk about is patient consumer leaders for kidney research and innovation. Our topic is in relationship to the patient's voices. And so I would like to highlight some of those voices to you today. So some of the things that we talked about during our meeting in February was racial inequalities in health and healthcare. What we found is that racial and ethnic minoritized population experience reduced access to quality of care. That means there was a decrease in referrals, home dialysis modalities, kidney transplant. But there was also an increase in greater risk disease, as in kidney disease or kidney failure. The importance of engaging patient consumers and stakeholders across the research continuum as true partners in research was a major thing. Since patient consumer voices played a central role in designing interventions that address structural racism to reduce kidney health disparities, it is appropriate to be reminded of the essentiality of their voices in this discussion. The patient consumers and other stakeholders presented real life experiences that we were able to compile to form a clear and concise strategic plan. So what is structural racism means to patients is the real question in the goal of the patient panel, which we had during our meeting. The patient consumer panel primary goal was to understand better the most critical areas that needed to be addressed and identify topics that should be discussed during the work group sessions. Now, I am in no way in the position to tell you about the experiences of each patient's voice, but I will attempt to express some of the noted expressions shared at the meeting in February. What I have here are some examples of what the voices of some of the patients stated. Patient consumer one, her name was Miss Claudia Camacho. She was an interpreter with Denver Health Medical Center. She shared with us that she came from Mexico at age 17. She started working at Denver Health Center as an interpreter. Her job description was to tell patients that they could not get dialysis because they were not sick enough. The interesting thing is that her dad got diagnosed with ESRD, and because he was a citizen, he was able to receive dialysis. And her experience with this included not being clear on what to do. She received no education, and neither did her father. They lacked resources. When she became a patient navigator in a research study, she learned about ESRD and resources available to patients. Now, she lived with knowing that if she had the right resources, her father may still be alive today. Here are some concerns she noted. She had concerns about both cultural, bilingual, and communication barriers. Now we have patient consumer voice 2, which is Miss Dawn P. Edwards. Now Dawn, she started dialysis at age 23 years old. She was not invited to share in her treatment planning as she shared with us. Decisions were made for her about what treatments were best. Assumptions about compliance were in questions for her. She was even told that the only option for her was in-center hemodialysis. She experienced stereotyping on all levels. Now, what Ms. Edwards did for us at this meeting is that she brought a consciousness to the importance of assessing patients' environment and access to food and resources needed in poor communities. She also highlighted educational implications that was needed for receiving a transplant. For example, what she didn't know is that after 3 years, you lose your benefits. She thought that that was something to highlight. Ms. Edwards said she experienced several incidents of racism without realizing that she was a victim of racism. Next, we have patient consumer voice 3, Dr. Patrick O.G. One of the things he expressed was a need for cultural diversity and competence training. He stressed the importance of having a diversified workforce. Example, having people that look like the patients. He asked us to stop stereotyping individuals based on what you see. He said that patient needed to have fair treatment. And lastly, he said, we needed to engage in tough conversation with patients by asking about their backgrounds as a method to breaking down systemic bias and profiling. Next slide is yours truly, me. Now, my kidneys began to fail 3 years before I actually went on dialysis. My position as both a professional and a patient has enabled me to identify a false duality in healthcare. What I found was that social determinants can perpetuate stigma. For me, going into a provider's office and being assessed from the door based on predeterminants and social characteristics, example, stereotypical ideas about people of color and gender. I experienced that. I experienced that at a particular visit. And so for that, stigma, I see, and from my experience, has been the catalyst to fail health outcomes. And when patient presents a problem, we come to the table with already established social determinants of health based on the literature, rather than factoring the patient as a different individual, because each patient is different. I also experience issues, and I've talked to other patients about issues of trust and mistrust. Medical history has failed. So the experience in the meeting overall, patient consumers had a conclusion. And the conclusion patient panelists concluded was that cultural diversity training is needed as we diversify the workforce. Patients should be able to participate in shared treatment decisions making without being victims of assumptions made related to health behaviors, social determinants, which can affect treatment outcomes and modality options. Health professionals should understand the nature of non-English speaking individuals. Invest in interpreters and learn about the individual's culture. And medical professionals should spend more time learning about their patients and understanding patients' social context. Example, neighborhood, environment, household structure, accessibility to healthy foods rather than making assumptions or blaming patients. Other areas that were identified included the need for interventions to improve patient education and engagement in shared decision making regarding kidney replacement treatment options, and the need to improve patient-provider communication and language inappropriate and literacy appropriate services that address patients' social challenges. Example, transportation. So I'll yield the floor. Dr. Norris will further expand. Thank you.
Thank you, Katina. And again, thank you, Richard and AAKP. It is a pleasure to be here today. And as Katina said, I will provide a little more detail about some of these factors that lead to the health differences we see in many patients as it relates to kidney disease. So one problem we have are these health inequities, different resources that can contribute to health or contribute to disease, and they are distributed unequally and through racial discrimination built into laws and policies, and we call that structural racism. And if we can address that, we can hopefully create more health equity. Racism is really defined as a system of structuring opportunity and assigning value based on race. So it's not whether or not you like someone or don't like someone, it's a system. Those are biases, but racism is a system. And the system unfairly disadvantages some individuals and communities and unfairly advantages others. And by doing that, it takes away the strength of the entire society by wasting human resources. And this system called racism operates at multiple levels. What we call structural or institutionalized racism, that may be racism based into laws or policies in society at large, in a hospital system, in a health system. There's personally mediated racism, but that's what we're more commonly familiar with, where individuals act discriminatorily against others based on their race. And then there's internalized, how someone takes all this in and how it affects them. When we think about race, it's important to know that race is socially assigned, and simply put, race is how society sees you and thinks of you. While racism is what society does to you based on how it sees you. And that's important because race itself is not a risk factor for health. Race is a risk factor for racism, and racism is a risk factor for poor health. And so a common definition of structural racism is the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems. And as we just heard, that can include housing, education, employment, healthcare, and more. And that reinforces discriminatory beliefs and values, the distribution of resources, and really leads to increasing or decreasing one's risk of adverse health outcomes. And there's been substantial evidence describing kidney-related health disparities and many of the factors that may contribute to that. But there's less research on interventions to mitigate or decrease or eliminate kidney health disparities. And so many factors that we've addressed have sort of focused on behavior change at an individual level, but very few have addressed structural factors, structural drivers that perpetuate inequities in health and among individuals living with kidney disease. And so what we want to do through this workshop was think through what are more structural factors that could be intervened upon to try to help improve health outcomes for all patients with kidney disease. So the workshop objectives were to describe the mechanisms through which structural racism contributes to health and healthcare disparities for people along the continuum of kidney disease, and most important, to identify actionable research recommendations for interventional research. So some of the themes for future interventional research strategies included applying an anti-racism lens, promoting structural interventions that could be at the level of neighborhood food, educational systems, housing support for unhoused, things of that nature. Importantly, workshop talked about targeting multiple of these socio-ecologic levels and domains of influence at the same time. Can we, at the same time, promote authentic community and stakeholder engagement? It's critical that we work with our communities to make sure that we hear their voices, understand their insights, and leverage their expertise and knowledge if we're going to make effective interventions. We then need to improve our data collection. And finally, we want to advance health equity through many of these new healthcare models. So again, potential interventions may include, one, increasing access to care for more and more people, and the Affordable Care Act has improved that, but there's still a ways to go. Looking at reformation of incentives for providers and making sure that the payments are incentivizing people to do the right thing and the right thing for patients. Potential food environment interventions such as tax credits or zoning laws, or providing food, housing, and income support, particularly to high-risk patients such as pregnant mothers. Other interventions might include kidney navigators, and those may be peers, community health workers, or promotoras. There also may be new models of care delivery, bringing healthcare to the patient through mobile clinics, and also thinking about the integration of social and medical care. And finally, how do we use telehealth and broadband access to enhance access to care? So again, some strategies to improve and address what many racial and ethnic minority populations are experiencing. If we can make equal access to and equal quality of care for patients through nephrology referrals, home dialysis modalities, kidney transplant, that would be amazing. And also, if we could change the profile so that all persons have a similar risk of disease, a similar risk of kidney disease, a similar risk of kidney failure, then we would know that we're attenuating structural racism and that there's now equity in the distribution of these resources and opportunities that impact health. So we would like to give a special thanks to the organizing committee, panelists, moderators, and facilitators. A special call out to Dr. Raquel Greer for her leadership in this initiative, that the NIDDK workshop, and her support for materials for this presentation. I've listed here members of the organizing committee, and you'll see the names of many individuals who are participating in the AAKP program this year, and also many of the panelists, moderators, and facilitators, including Katina Lang-Lindsey and myself, who are fortunate enough to have the opportunity to present this information, and Richard Knight for helping to organize this and his long-term leadership in AAKP. So we want to end this by saying each nation, by its customs, its laws, its principles of thought, creates for itself a pathology appropriate to itself. A society chooses its diseases and shapes its pathologic destiny. So we're hoping that the structural racism that has shaped our pathology and our diseases is something that we can overcome with these interventions. And we thank you for the opportunity to share some of the results of the workshop with you. Thank you.
Thank you, Dr. Norris, and thank you, Dr. Lindsey. And I'd also like to add, on a very personal note, I want to thank each of you, along with Dr. Greers and Dr. Norton and others who played a leading role in the recent designing interventions that address structural racism to reduce kidney health disparities. That was a landmark workshop, and we look forward to seeing the the write-up of that particular activity.